Good evening, sir. Good evening, ma'am.
Margi, can we start?
Yes, sir. Yes, sir. Good evening.
My internet is not working very well. So you continue with that. I will be joining in 10-15 minutes. Okay. So we can start now.
Okay. Good evening, everyone. I'm Dr. Margi Hirpara, second year resident from Tuesday Surgical Unit. Today's topic for lecture is journal reading on superior mesenteric artery syndrome. This is compression of duodenum between aorta or vertebral column and superior mesenteric artery leading to obstruction. It is a rare disease with prevalence of 0.1 to 0.3%. Age group is 10 to 30 years. Females are affected more compared to male. It is obstruction at D3 level where duodenum crosses the superior aorta. In CT, we can see decreased aortomesenteric angle to less than 25 degree, which is normally 38 to 65 degrees. And there is decreased aortomesenteric distance to less than 8 millimeter, which is normally 10 to 28 millimeter. Treatment is either conservative or surgical. This is the normal angle, which is usually 45 degrees. The range is 38 to 65 degree. When the mesenteric fat pad is lost, or when the lumbar lordosis is increased, the angle decreases and the duodenum is compressed in between the superior mesenteric artery and aorta, leading to obstruction.
Which part of duodenum?
Ma'am, third part of duodenum.
Okay.
This is the barium study showing
Margi, is there anything like primary and secondary? Primary SMA syndrome and secondary?
I don't know.
Does literature say so? No. There is nothing like primary and secondary. So what are the causes? Have you gone through the causes of SMA
Yes, sir.
syndrome?
Yes, sir. It can be either congenital.
Very
or-
good. The commonest cause is a congenital. Most of the 80% of the SMA syndrome is congenital. What do you mean by congenital? Where is the pathology?
Sir, in congenital, the ligament of trace can be shortened, which
Very
will
good.
lead to which will pull the duodenum upwards,
One.
and
Second reason,
hypertrophy of ligament of trace or low origin of superior mesenteric artery.
yes. Anything else? Does
Commonest
it
cause
have
of
a relation with
SMA
malrotation?
syndrome.
Sorry, ma'am, I didn't get.
Can you hear?
No, ma'am, I didn't get the question.
Commonest cause of superior mesenteric artery syndrome. Congenital cause. Commonest.
Short
Large
ligament.
band. Large band. Most of the patients, they are having large band. And that also give rise to superior mesenteric artery syndrome. Okay.
Then there are acquired causes. It can be significant weight loss, which leads to
No, Gargi, how does the large band will cause superior mesenteric artery syndrome? Means yes, agreed. But how does it cause and what is large band? You know that for benefit for others, just tell me what is large band and how does it cause superior mesenteric artery syndrome?
sir, it is a band of peritoneum which connects cecum to the right abdominal wall.
Or liver, right? So
It
what is large
extends
band?
from the
Why there is
duodenum,
large
second part of duodenum. It extends from the second. When newborn baby is affected, at that time it is from the second part of duodenum extends to the liver. That is the one part. Second part is from the first and second part of liver to the third and fourth part. Right? So when it extends beyond the third part, then it produces superior mesenteric artery syndrome. Right? Okay.
And normally when the derotation occur inside the abdomen, incomplete, it can cause superior mesenteric artery syndrome. Or one is there can be a normal rotation, then there will not be superior mesenteric artery syndrome. And one there will be complete derotation, that is 360 degree. Then also there will not be superior mesenteric artery syndrome. But if it is a 180, 90 or 270 degree malrotation, the patient can have a presentation as a superior mesenteric artery syndrome. It is either isolated superior mesenteric artery syndrome or may be associated with mobile cecum leading to true features of malrotation. But one of the reason, how will you differentiate it? Is a malrotation only or superior mesenteric artery syndrome?
Sir, I don't know.
Did you hear my question?
Yes, sir. I don't know the answer, sir.
Very good. That's all right. No problem. The point is that if it is a malrotation, there will be double bubble appearance, which will also be there in case of superior mesenteric artery syndrome. But if you find a double bubble appearance, it is a classical feature of malrotation, where the obstruction is the, as Madam has said, the second part of duodenum. So their first part and our proximal second part of duodenum will be distended along with the stomach. Whereas in case of superior mesenteric artery syndrome, double bubble appearance is very, very rare. There can be distension of whole stomach because the obstruction is at the level of third part of duodenum, right? Sometimes this is the primary cause. Other causes continue.
Sir, in acquired causes, it can be due to a loss of mesenteric fat, which will occur in profound weight loss. In this case, the mesenteric fat is lost and the duodenum is compressed between the SM and aorta. And the other causes would be increased lumbar lordosis,
Yes.
which will decrease the angle. Then application of cast, which
So
was
what is the age for increased lordosis? What is the age group?
I don't know, ma'am.
As you said, it female are more affected. So usually menopausal age group female who are having lordosis because of the osteoporosis, they are mainly affected at that age. Okay. Continue.
I would be presenting 3 articles. One is on...
Okay, that is fine. Margi, one more thing in our country we should keep in mind is a tuberculosis. Right? Tuberculosis also affect and can cause superior mesenteric artery syndrome by 2 ways. One is profound weight loss on its own. And second is formation of mesenteric node at the root, which is near the superior mesenteric artery, which become thickened and can compress duodenum. That is also one of the cause of superior mesenteric artery syndrome. With the lymph node which are caseated becomes fibrosis and decreases the angle between aorta and superior mesenteric artery, leading to formation of this. Okay, so that should also be kept in mind, though rare, and it should not be ideally called superior mesenteric artery syndrome, but the symptomatology and presentation is similar, so it should be kept in mind. Okay, continue.
I would be presenting 3 articles. First is diagnosis and treatment strategies for superior mesenteric artery syndrome. Second would be a case series on SMA syndrome surgical management. Third would be a short case series of 2 cases on conservative versus operative management. The first article, diagnosis and treatment strategies. It was published in Journal of Gastrointestinal Surgery 2009. It was undertaken at Bankston, Australia, over the period of 5 years. From 2002 to 2007, it was a combined prospective and a retrospective study. It enrolled 8 patients, 7 were female and 1 was male. As we can see, it included following characteristics of patients and compared it: age, gender, associated comorbidities, symptoms, length of symptoms, weight loss, diagnosed CT scan findings, and post-operative weight gain. As we can see, most of the patients, all the patients were varying age group of 18 to 32 years, and all the patient had symptoms of vomiting, reflux, and these symptoms were long-standing from 8 months to 24 months. All the
Most
patients
of them are female, only 1 male.
Yes,
see, you can see all are female except 1.
Yes, all of the patients had profound weight loss ranging from 20 kg to 40 kg. All these patients had associated comorbidities in the form of drug use, binge eating disorder, diet. One of the patients was on dieting, and there were other issues like domestic abuse and social issues. All patients, when presented, had complaint of vomiting and reflux, and 2 of the patients had electrolyte abnormalities, which needed to be corrected with intravenous correction were given to these patients. Then all the patients were underwent multiple investigation before they came to final diagnosis. All of the patients underwent UGI-scopy and were diagnosed to have refluxes, non-specific esophagitis, and were treated with NSAIDs. Were treated with PPI. And after suspicion of superior mesenteric artery syndrome, they underwent contrast imaging in the CCT abdomen was done for this patient, and it showed dilated duodenum up to D3, and it showed decreased aortomesenteric angle. And the findings in our patients, the aortomesenteric angle was decreased, ranging from 9 to 18 degree. which is less than 25, and it was diagnostic for superior mesenteric artery syndrome. All these patients underwent surgery and all these patients underwent duodenojejunostomy. Only one with laparoscopic approach, other with open approach. And
Sorry, beta. So what did you say treatment? Because it's a very small letters, I cannot read it. Okay. So what was the common treatment?
Sir, all the patient underwent duodenojejunostomy.
Why not gastrojejunostomy? Any reason they have given?
No, sir, it was the procedure of choice in this.
I say it is right, fine. But as a PG student, you should know why DJ was preferred. It's a very, that's why we do journal reading. You should have very clear idea that DJ is a treatment of choice, but why?
Sir, it is preferred over gastrojejunostomy as it doesn't have the disadvantage of reflux.
Of what reflux?
Bile reflux and blind loops.
Reflux of what? Bile.
Bile.
So how GJ is causing reflux? How will it cause the reflux?
The pathology is not addressed. The obstruction is still there at the level of duodenum. So the bile will...
No. How the obstruction is there still there? It will be even if you do DJ, obstruction is there. Because we bypass the obstruction site. Do you understand? We bypass the obstruction site. So it is that GJ is also bypassing the obstruction site. DJ is also bypassing the obstruction site. So how the difference is that? Why DJ is preferred? Remember one thing. Whenever there is any pathology, you should stick to nearest normal anatomy for a treatment. Right? Do you understand? So when you do GJ, you bypass the pylorus. But when you do DJ, pylorus is still there, stomach function is preserved, and patient's growth is good. And second is what you have said, bile reflux is more common, stomal ulcer is also more common. So DJ, whenever is possible, is preferred. Have you read anything about DJ? How the DJ is done?
Sir, it can be done by two approaches. The first, the duodenum is the fourth part of the duodenum is preserved, and in second, the fourth part is transected, and the jejunal loop is brought.
Why fourth part is transected? I don't get it.
Was it written in the journal? Was it written in the journal? Margi.
Yes, ma'am. It was written in the journal.
That they transected fourth part. It was written like that.
With the duodenojejunostomy with transection of fourth part of duodenum.
And what is closed?
Yes, sir. It was.
And the end of that part is brought to the DJ for a duodenojejunostomy?
Yes, sir.
Have you got it here written somewhere? I would like to see. This is something new for me.
Because routinely we do not transect the fourth part in DJ.
Sir, this is the diagram. In this, the D image shows the fourth part of duodenum is divided, and the jejunum is brought near the third part and anastomosed.
So what about third image? C, in image C.
Yes, sir. Sir, the fourth part is not divided, and the loop is brought and anastomosed to the third part of duodenum.
So in your journal, how many % had gone transection of duodenum?
Sir, all of them. All of them, sir.
It was a standard treatment?
Yes, sir. That was written in the...
So which year journal is it?
Sir, 2000, ma'am, it was published in 2009.
It is very unusual. Normally, we do not do this type of transaction. We do Roux-en-Y loop and do an anastomosis proximal to the dilated part of the duodenum. Means obstruction proximal to the obstruction. So it is a Roux-en-Y anastomosis, not like this, near the DJ.
This is something unusual, surprisingly.
Surprising.
Not a
It is
copy of
not
that
written
book
in book also. It is not written in the book also.
That's why I'm surprised. Have you got the copy of whole article?
Yes, sir.
So tomorrow at Monday, I would like to have it because this is something new. So even if when we do DJ, we don't do with the third part. We do at the second part of duodenum. That is the normal procedure we do. We put a oblique incision on duodenum and join the jejunum. Roux loop of jejunum is joined.
Because we get wider area there and good vascularity there.
Here the problem is third part of duodenum is not approachable easily. You will have to do lot of dissection to expose the third part of duodenum, because do you understand it is covered by uncinate process partially and it is very close to pancreas, whereas the first and second part, early second part of duodenum is easily accessible and you can go there very well. Only problem is you have to bring the jejunal up through the mesocolon or above the mesocolon. Normally we bring through the mesocolon. That is a better way to do it. GJ is usually not done. We normally do this procedure, that is known as a DJ. Here he has joined with the third part of duodenum, but we normally join with the first and second part, which is accepted. Because even in all congenital condition, if patient has a congenital duodenal atresia, wave or a membrane, we do the DJ with the second part of duodenum. So this is something unusual. Even I have not read it in book.
Yeah, I have also not seen any book like this. Dividing duodenum near the Treats ligament.
We normally divide 30 centimeter away and do the JJ and do the DJ. Like that is a normal phenomenon. I will have to read. I cannot opine. Okay.
No, but in most of the textbook, what you said, it's written in all the textbook. This might be something unusual thing. Okay.
That is good, but you have taken this journal, so at least I come to know. So for all PGs, the common is DJ, second part of duodenum and Roux-en-Y. I don't think I have seen it joining with the third part of duodenum.
Because doing anastomosis in the anti-mesenteric part of third part of duodenum is difficult. It is covered with the mesocolon, even it's very difficult.
And it is retroperitoneal structure.
Retroperitoneal also.
So it is very difficult to do it. I don't know why he did it, and that is all right. But you should keep this in mind that this is not a routine. Yes, for journal point, so I would like to see and read and what are, so okay, come to the result. What are the results?
Mean duration of symptoms in all this patient was 18 months. So it was a long-standing disease, and it is usually misdiagnosed earlier, and most of them were treated as GERD, and all had significant weight loss. And after surgery, all of the patient in all the patients, they observed weight gain up to 6 months. Then the weight gain was static. All the patients in the study were treated with duodenojejunostomy.
Okay, Marty, so what will be the common patient according to them? Common presentation, type of patient, age, and other things.
Young female with history of a long-standing history of vomiting and upper abdominal pain.
Very good. So young female is a commonest, and failure to gain weight is more common than weight loss. Static weight, most of them patients are thin, lean, right? Young female, usually treated as having a anorexia nervosa or having a psychological problem, because the symptoms are minimum, usually postprandial pain or maybe associated with occasional vomiting. Previously, this was very difficult to diagnose, so it was not very common. Now it is becoming more and more common because of the good imaging techniques, right? Is there any role of MR? Have you read it anywhere?
MR angiography can be used to diagnose.
It is said plain MRI has not much value, but MR angio can exactly delineate the angle between the supramesenteric and aorta. But still, it is not proven. The best is CT and with the measuring of the angle and associated with symptom. It is rather diagnosis by omission, because upper GI scopy is an important investigation which should be done in all the patient of this. Right? It is ultimately many a time, apart from GERD, patient present with gastric outlet obstruction. That is the second common condition it is mimicking. So most of the time in today's scenario, upper GI scopy is done. So what will you find in upper GI scopy of the patient having this?
Reflux esophagitis, and dilatation of duodenum.
But before that, grossly dilated stomach. Understand? Right? Second is pylorus is patulous. The normal sphincter mechanism of pylorus is disturbed because of the persistent dilatation, and duodenum also appears to be dilated. There can be a bile reflex in the stomach, which can be seen very commonly inside, right? So that is an important point. And sole purpose of surgery is patient who is not thriving will thrive. That is important. So weight gain may be variable. Some of my patients gain weight up to 20 kg, some gain weight up to 5 kg. But the most important criteria is that patient is felt is a weight will increase as per the age rather than static or stunted growth. And second, disappearance of the pain and GERD like symptoms, what you have said. Do you understand? So measurement is on that basis. So what he has said about this?
Sir,
Go back. This is the last 3 patients. How many patients of study was there?
8.
How many total patients?
8, sir, 8.
Only out of 8, 3 patients had to continue with psychological treatment. So understand, there is some functional element is also there, because the patient has not been diagnosed earlier and go on having a treated by various methods. So patient loses confidence, and many patients had a psychiatric problem. Thus, more important point, as patient continue to lose the weight, the fat pad around the mesentery goes away and symptom increases. So it establishes the vicious cycle. That should also be kept in mind. You have said very well, it should be kept in mind. That is a high degree of suspicious. Another problem with almost all patients is a misdiagnosis. A patient who is not having superior mesenteric artery syndrome may be diagnosed as a superior mesenteric artery syndrome and treated, because the recent weight loss can cause the change in angle between superior mesenteric artery and aorta, and which will be misdiagnosis as a superior mesenteric artery syndrome. And these patients may not respond to treatment. Do you understand? They having a more of a psychological problem, what you call anorexia nervosa. So those patients will not have a as good result as the actual patient who had a SMA before weight loss. So this is a very technical issue you should keep in mind. Weight loss increases the SMA syndrome, but the first thing, actually the weight loss occurred due to SMA syndrome or due to some other condition, and then the patient had a SMA diagnosed because of the weight loss and angle decreasing. This you should keep. I think, do you understand what I am talking?
Yes, sir. Yes,
Did
sir.
you understand what I am
Yes,
talking?
sir.
Okay. Continue.
The conclusion the author made is this is a very rare disease with a prevalence of 0.1 to 0.3%. Females are affected more, and the age group affected is 10 to 30 years. The contrast CT is the mainstay for diagnosis. Diagnosis requires a high index of suspicion, and surgical treatment should be allied with psychological assessment and treatment.
Very good. Okay.
The limitations of this study were it was a single institute experience, and there was smaller sample size, And there were other comorbidities as confounding factor for diagnosis. The second article, it is a case series on SMA syndrome surgical management. It is also a single institute study of 6 patients in Apollo Hospital, Chennai, from January 2010 to May 2015. It was published in 2017 in Journal of Clinical and Diagnostic Research. There were 6 patients. Four were male and 2 were female, from in the age group of 17 to 31. Most of the patient has symptoms of postprandial abdominal pain, postprandial blotting, and vomiting. And all the patient underwent CECT abdomen, and the aortomesenteric angle was in range of 7 to 12.5. So these patients were diagnosed to have superior mesenteric artery syndrome, and all of them, after a period of conservative management, ultimately underwent surgery. 3 of them underwent open duodenojejunostomy, and another 3 underwent laparoscopic duodenojejunostomy. Sir, on comparison, in open surgery, the operative time was lesser compared to laparoscopy, and patient's recovery was better with laparoscopic surgery, as the patient could be mobilized on the day of surgery. The post-operative pain was lesser, and hospital stay was lesser in laparoscopic surgery. Sir, overall, the long-term outcome was similar in both the kind of surgery, and the duodenojejunostomy has a success rate of 90%, whether it is done by open approach or a laparoscopic approach. The long-term, however, the immediate post-op recovery was better with laparoscopic than open approach.
Here, which type of DJ was done? They have mentioned?
Conventional type of DJs.
What is conventional? Was it a Roux-en-Y or tube? Sorry. Loop. It was a loop only. Okay. No Roux-en-Y. Not sure. I think you have not read it completely, or they have not mentioned. They must have mentioned whether it was Roux-en-Y or a loop.
Sir, it was a loop.
Loop. And which part of duodenum? They have also not written.
Third part, sir. Third part.
Third part. Okay. Next. Okay.
Limitations are similar. There were less number of patients, and long-term follow-up was required. Sir, the third article, it is the management of superior mesenteric artery syndrome by it is a short case series on conservative versus operative management. It was published in Current Medical Issues 2019 and done from CMC Vellore. Sir, the first case was a 21-year-old female who presented with epigastric pain and loss of weight over a period of 1.5 years. Her BMI at the time of presentation was 13.3, and she underwent CT scan and was diagnosed to have superior mesenteric artery syndrome on the basis of decreased aortomesenteric angle to 14 degree and aortomesenteric distance to 4 millimeter. And she was managed with conservative management with decompression of stomach initially, correction of electrolyte, and then sir NG tube was placed endoscopically, and she was started on feeding through that. And after 3 months, she gained weight, and her BMI was 17.7. And repeat CT scan was done, which was showing increased aortomesenteric angle to 38 degree and aortomesenteric distance to 11. And there was no persistent dilatation on CT scan. So the NG tube was removed and patient was discharged. Patient maintained her weight at 6 months. 6 months after discharge, and she was having no complaints then onwards. Sir, and she was managed with conservative approach. And the second case was 18-year-old male who presented with similar complaints, postprandial vomiting and epigastric pain, and her weight and his BMI at the time of presentation was 13.5, and he was diagnosed to have superior mesenteric artery syndrome on the basis of decreased aortomesenteric angle to 22 degree and aortomesenteric distance to 6 millimeter. And his CT scan showed dilated duodenum and stomach. And he also was given conservative management at present with NG tube. And at the end of 3 months, he gained weight and his BMI increased to 15.7. Aortomesenteric angle increased to 33 degree and aortomesenteric distance increased to 17 degree. But he had persistent dilatation of duodenum, and he also had symptoms of vomiting, and that's why he was diagnosed to have failed conservative management and was planned for surgery. Duodenojejunostomy was done in that patient, and after surgery, patient gained weight, and the surgery was done with NG tube in situ, and the patient was given NG feeding after surgery. Then NG tube was removed and patient was discharged, and patient had no symptoms then onwards. So
I remember one patient, we get one patient, 17-year female patient was having Guillain-Barré syndrome. And she was having repeated vomiting. So the medicine people investigated, and in that patient, they diagnosed as a superior mesenteric artery syndrome. We treated patient conservatively and discharged the patient. But within 1 month, again patient came with the same symptoms for 7 days. And so she requires surgery. So it requires long follow-up. So most of the patient requires surgery. Conservative treatment is temporary in most of the patients.
Another point which I had delineated, the principle of conservative treatment is based on two things. One is when your diagnosis is not very sure. Second, the patient who had a weight loss may be because of some other condition. Like in young female, what I have said, psychological factor. And when the patient is treated conservatively, she may have a gained weight leading to increase in angle. And there is a deposition of fat which acts as a buffer and the symptoms go away. But most of the time, if patient's angle is very less, conservative treatment may be time being and the operative treatment may be required. But you should keep in mind, that's why I said that basically that is a very difficult question to answer. Whether weight loss was first or whether SMA was first leading to weight loss, then it is very, so if when you are in doubt, patient is non-cooperative, patient is having a proven psychological factor, patient is proven to have a anorexia nervosa, or a patient, there is a definite background which suggests that the cause of weight loss may be something else. In those cases, there is a definite role of conservative. But most of the patient does not respond to conservative. So even today, in a proven SMA, the mainstay of treatment is surgery.
And if you treat conservatively, then you should call patient regularly for follow-up. That is most important thing.
Okay. Fine. You have taken any other journal? Actually, I forgot, Margi, I should have told you, Jhalak, our resident before 2 years, she had presented a paper in a conference in which we have treated 5 cases. Our method of treatment is totally different from this. I don't know whether, did you find any other method of treatment?
Margi.
No, sir.
So what we normally do in our institute is we do a derotation. So what is that? The principally the basic problem is third part of duodenum, right? Which is compressed against the supramesenteric artery. So we have presented that paper is that in that all those cases underwent derotation. So what we do in derotation is we bring the DJ on the right side. So third part of duodenum goes away like a large procedure what we do in case of malrotation. So there is no superior mesenteric artery and aorta compressing duodenum. So we do a derotation, bring the cecum on the left side and DJ on the right side. So it goes away. I think one of us can ask, and we should have, I forgot, but that should have been presented as a one of the treatment. Where
Three of my patients also you operated it in my 3 patients. So it's more than 8 patients.
it's a more than 8. We have done quite, actually my study is about 24 patients, which we have operated, in which all of them underwent derotation. So what we do in large end procedure that we derotate, first we do kettle maneuver, cecum and hepatic flexor is separated and it goes on the left side and we do rotate on the mesentery. So that way superior mesenteric artery is rotated. So DJ will come on the right side, cecum will go on the left side. So there is a no third part of duodenum anymore. So that will automatically prevent the reappearance of symptoms and results are very good. We have also operated patient who had 8, 10, 15, 17 kg weight gain. So that is a one more treatment, derotation or a large procedure in superior mesenteric artery syndrome. Even if there is no malrotation, we can do this treatment and it works well. Okay, anything else you would like to add in?
No, that's fine.
Okay, thank you, Margi. You did good job. Thank you.
Thank you, ma'am.
Thank you.